All right, great talk, Evan. So now it's my pleasure to introduce our second speaker for this first session. I'd like to introduce Mary Farid, who's one of our gastroenterologists here in Santa Monica. And we could probably give her all day to talk about this issue. She's going to talk about upper GI functional disorders. So, Mary.
Okay. All right. Okay, thank you. So good morning. Thank you all for coming. I'm going to be speaking to you about functional disorders of the upper GI tract. Later this afternoon, you'll be hearing from my colleague Lynn Connolly about functional disorders of the lower GI tract. So I'm going to start by this slide because this will apply to all of the disorders I'll be discussing this morning. Many of the disorders we'll be talking about have specific clinical criteria that are required in order to make the diagnosis, but they all have one thing in common, and that is the criteria need to be fulfilled for at least 3 months with symptom onset at least 6 months prior to the diagnosis. So keep this slide in mind because this will apply to all of the conditions we'll be talking about today. So let's jump into our first case. We have a 42-year-old woman who presents with a persistent sensation of a lump in her throat. This has been present for 9 months. At first, she attributed the sensation to postnasal drip, but now she's concerned and she feels like there's something stuck back there. The sensation is really unrelated to meals. She denies any dysphagia, odynophagia, heartburn, reflux, or regurgitation. She's concerned because she's lost about 5 pounds in the last year, and she has a history of heavy tobacco use. What is the most likely diagnosis for this patient? So we have this 42-year-old woman with a lump in her throat. She smokes. She has lost 5 pounds. A, GERD. B, esophageal cancer. C, Globus sensation. D, head and neck cancer. Or E, achalasia. Okay, here we go. Okay. So we had about a quarter worried about esophageal cancer, some concern for head and neck, achalasia, and Globus sensation. Okay. So we're going to hold on to this question, keep it in the back of your mind as we talk about Globus sensation. So this case was to illustrate a very common presentation of a patient who presents with Globus. Globus is defined as the persistent or intermittent non-painful sensation of a lump or foreign body in the throat. It typically occurs between meals. There is no dysphagia or odynophagia. There's no evidence of GERD or acid reflux as a cause of symptoms, and there's actually no evidence of a motility disorder. The median age for Globus sensation is 43, but there can be a wide range. You can see young patients in their 20s or older patients in their 70s. The prevalence is 3 times more common in women under the age of 50, but actually over the age of 50, the prevalence among men and women is equal. Oftentimes, they've had symptoms for over a year by the time they finally come to be evaluated. The etiology really is unknown, but there is some suggestion that it may be linked to visceral hypersensitivity or other anxiety disorders. So an interesting case series that was published in 1998 looked at 88 patients who presented to a psychosomatic center with Globus sensation. And the most striking finding of this study was the high proportion of patients who actually had achalasia. Interestingly, these were patients who did not report any other symptoms consistent with achalasia. The only symptom that they had was Globus. And the thought is that the persistence of food and fluid in the esophagus between meals in patients with achalasia is what causes the Globus sensation. Later, after these patients were diagnosed, they were questioned, and actually many of them did report at least one symptom that was consistent with achalasia, but it wasn't severe enough for them to volunteer the information during the initial office visit. So this brings up a very important point that all patients with Globus sensation need to have a very careful history and physical with a focus on identifying signs and symptoms of achalasia. So the questioning and the history taking is key. These patients should be referred to ENT to rule out any structural abnormalities, underlying malignancies, particularly in patients with risk factors as our patients had. Appropriate endoscopic evaluation should be done for those patients who have Globus sensation, whose symptoms have changed, if it's a new symptom for them, especially in older patients or any patients with alarm signs. And alarm signs, of course, being weight loss, dysphagia, anemia, or anything else that can be concerning. Further diagnostic testing can be considered, but it really is individualized based on the patient and what their symptoms are. Other studies that can be done include a video swallow evaluation, esophageal manometry, or pH monitoring. But oftentimes the condition will essentially be unexplained in many patients. So how do we treat patients with Globus? There's some studies that have shown an empiric trial of PPI therapy can be beneficial. Small observational studies have shown that about a third of these patients do get better with PPI therapy, particularly if they have symptoms that overlap with GERD. Predominantly, the main focus is providing explanation and reassurance to the patient. If they continue to have symptoms that are very bothersome to them and they've had a negative workup, they can be referred for relaxation therapy. There was a small study that showed significant improvement in women, in particular with Globus Sensation, who underwent hypnotically assisted relaxation therapy. And if all else fails and it really continues to bother them, you can consider a trial of a tricyclic antidepressant such as imipramine. But I think the cornerstone really is reassurance for the patient. Okay, let's get to our second case. We have a 30-year-old male who complains of chronic vomiting for 5 years. He comes in and says, "Doc, I vomit every day. During a meal or after he's finished, the food just comes right back up. Often the food will have the same taste and consistency, and he may chew and swallow it again. Other times he might spit it out, but it depends on the social situation." Kind of gross. This may happen several times during a meal. He actually denies forceful retching. He mentions that the vomiting comes on pretty easily. He doesn't really have any associated warning signs. He has no abdominal pain. He has no nausea. It just comes right back up. In between meals, however, he feels fine. There's no nausea or vomiting, and he denies any symptoms of acid reflux or dysphagia. Okay. So this case is meant to demonstrate a very classic presentation for rumination syndrome. I'm not sure how often you see this in your practice, but we see these at least a few times a year. The definition of rumination syndrome is the persistent or recurrent regurgitation of recently ingested food into the mouth with subsequent spitting or remastication and swallowing. The key clinical characteristics are that the regurgitation is not preceded by retching and is not preceded by nausea. It's quite effortless. The process can occur over and over again during the same meal, and eventually it stops when the regurgitated material becomes acidic or when it's no longer pleasant. The patient often can mention that the food is recognizable and it's pleasant to them. Yeah. Other clinical characteristics of rumination syndrome is that these patients often have symptoms for years and they've seen many physicians. And the problem is because it often goes misdiagnosed because they come to you complaining of vomiting. And this is their perception that this is vomiting. But actually it's not vomiting, it's regurgitation that's effortless. The repetitive regurgitation typically begins within a few minutes of the start of the meal. Again, this is in contrast to vomiting that you may see with gastroparesis, for example, which typically occurs later in the postprandial period. So it's very important to take a good history and identify what the patient means when they say vomiting. The episodes often last 1 to 2 hours. Again, it's effortless or can be preceded by belching, and often the patients make a conscious decision regarding the regurgitant, and this often depends on their social situation. So if they're out or if they're home, they may spit out the food or decide to chew and swallow it again. So the pathophysiology of rumination syndrome has been looked at and is thought to originate from a rise in the intragastric pressure, and this occurs with a voluntary contraction of the abdominal wall. Even though it's voluntary, it's thought to be often not intentional. So they'll contract the abdominal wall. This causes an increase in the intragastric pressure. The increase in the intragastric pressure overcomes the pressure of the LES, and this causes the lower esophageal sphincter to open. When this happens, gastric contents flow from the esophagus, from the stomach into the esophagus. When you have gastric contents in the esophagus, this causes the upper esophageal sphincter to relax, and then these gastric contents flow into the mouth or the pharynx. It's thought that stressful life situations or anxiety can often trigger this process, but oftentimes an obvious trigger cannot be identified. This can also occur in patients who have GERD or in patients who experience uncomfortable abdominal sensation leading to belching, and belching can then trigger the rumination process. So this slide is meant to demonstrate some of the key differences between rumination, vomiting, and reflux. Again, rumination is effortless. There's no association with retching or nausea, whereas classic vomiting does have those things. Rumination is typically associated with recognizable food, whereas reflux is really just acidic material. And the interesting note is that weight loss can actually be seen in patients with rumination. Up to 80% of these patients actually have reported weight loss. So many times rumination syndrome can simply be diagnosed clinically. Not all of these patients need a clear diagnostic workup. It depends on their overlapping symptoms. So if they do have overlapping symptoms of acid reflux or possibly an underlying motility disorder, then it would be reasonable to obtain an esophageal manometry study or pH testing. Combined manometry and pH impedance is helpful because this can differentiate rumination syndrome from acid reflux. Patients with rumination can demonstrate an increase in the gastric pressure greater than 30 millimeters of mercury at the same time that esophageal reflux episodes are occurring. So this does not occur with GERD. Again, if you have a patient who actually has retching or nausea, then you need to evaluate them for classic vomiting. That's not rumination. So how do we treat rumination syndrome? Again, similar to Globus sensation, a thorough explanation and reassurance for the patient is often all you need. These patients can be referred to a behavioral therapist to work on their diaphragmatic breathing exercises. It's thought that diaphragmatic breathing can help reverse this behavior and compete with the urge to contract the abdominal wall, which is what triggers the whole process of rumination. Okay, so we have our third case. We have a 56-year-old woman who presents with 1 year of intermittent postprandial epigastric pain, can last for hours at a time, not associated with any nausea or vomiting. She often feels bloated. She has excessive gas and belching. She feels very full after meals. She has tried PPI therapy many times without relief. She does not have GERD, weight loss, dysphagia, melena, or a change in bowel habits. What should be the next step in the management of this patient? So we have a 56-year-old woman with bloating, pain. She's tried PPIs. It's been going on for a year. A, check H. pylori serology and treat if positive. B, check H. pylori stool antigen and treat if positive. C, try a different PPI and make sure she is dosing it appropriately 30 to 60 minutes before meals. D, refer for an upper endoscopy. Or E, start a tricyclic antidepressant. Okay, so we have some good variation here. Check H. pylori stool antigen, refer for upper endoscopy, some like serology, and a few of the others. Okay, so this case demonstrates the classic presentation of dyspepsia. So dyspepsia is defined as the chronic or recurrent pain or discomfort centered in the upper abdomen. Discomfort is really sort of a subjective description. This refers to a non-painful sensation that can include nausea, bloating, fullness, just a general discomfort that's not pain. These patients who present with predominant heartburn or acid reflux symptoms should be considered to have GERD and not dyspepsia because there is some overlap. So this is taken from the American College of Gastroenterology guidelines on how to evaluate uninvestigated dyspepsia. The focus of our talk today will be functional dyspepsia, but before we can discuss functional dyspepsia, we need to know how to manage a patient who initially comes with these symptoms who's never had a workup. So it's recommended that any patient with alarm features or any patient over 55 should have an upper endoscopy. So our patient actually was 56. So the answer to that question was that she should be referred for upper endoscopy for that reason, although I'll be talking about functional dyspepsia. Alarm features, of course, again include anemia, GI blood loss, weight loss, any family history of GI cancers, prior history of peptic ulcer disease, abnormal physical exam, anything that's alarming. And that if they do have those alarm features, whether or not they are over 55, they should be referred for an upper endoscopy. Otherwise, in younger patients who are under 55 without any alarm features, there are two main treatment strategies, and that includes testing and treating for H. pylori or beginning an empiric trial of PPI therapy. Testing and treating for H. pylori is typically done with H. pylori stool antigen or the breath test, or if they're going to have an upper endoscopy, a biopsy should be done. The H. pylori serology is not really recommended. If these patients fail both the PPI trial and the test and treat for H. pylori, then the next step would be upper endoscopy. So now we have a patient who went through the process, had an upper endoscopy, it was negative, they failed PPI therapy, they failed H. pylori eradication, they continued to have symptoms. Now we can say functional dyspepsia. Functional dyspepsia is defined as the presence of one or more of the following: bothersome postprandial fullness, early satiety, epigastric pain or burning, and no evidence of structural disease, including an upper endoscopy. So really a negative upper endoscopy is required to make the diagnosis. The pathophysiology of functional dyspepsia is thought to be multifactorial. Delayed gastric emptying plays a role. Several studies have shown up to a third of these patients have delayed gastric emptying. There is evidence of impaired gastric accommodation in response to a meal, like a stiff fundus, as well as visceral hypersensitivities. Many studies have shown that these patients have a hypersensitivity to acid. They are more likely to report nausea in response to an acid infusion into the duodenal bulb. They also have a lower threshold at perceiving pain when the stomach is distended. The treatment for functional dyspepsia includes a PPI trial and treating for H. pylori, as we discussed. A large meta-analysis which looked at over 3,000 patients showed a modest improvement with these measures, but oftentimes patients will continue to have symptoms. If there's no improvement after 8 weeks of a PPI, for example, then a trial with a tricyclic antidepressant can be considered. And the typical choices are desipramine or amitriptyline, beginning at a low dose and then titrating the dose upward depending on their response. Prokinetics can also be considered in short courses, such as Reglan or domperidone, which can be obtained from a compounding pharmacy. Lyrica is kind of the new kid on the block. It's considered to be effective in those who fail the above therapies, although there are really no specific trials looking at Lyrica and functional dyspepsia. Most of the evidence in support of its use is largely indirect from psychiatric trials, but it is thought to modulate the brain signals and reduce visceral hypersensitivity. Other options include cognitive behavioral therapy, hypnotherapy, and psychotherapy, especially in those patients who are motivated and who identify certain stressors with their symptoms. Okay, so home stretch here. This is our last case. We have a 22-year-old male who presents with 2 years of recurrent intermittent nausea and vomiting. The episodes occur without warning and are not related to meals. He will have nausea, abdominal pain, repeated episodes of retching and vomiting, which can last for hours or up to 3 days. He's been to the ER 4 times in the past year, and he is typically treated with IV fluids and IV antiemetics. In between these episodes, he feels perfectly well without any nausea or vomiting, and he's not had any weight loss or change in his bowel habits. So which of the following are typically associated with his condition? A, a history of marijuana use. B, a history of migraine headaches. C, a family history of migraine headaches. D, improvement with PPI use. A, B, and C only, or all of the above? Okay, So I think we all agree that marijuana use, migraine headaches are associated. There's some different thoughts about PPI use. So let's talk about cyclic vomiting syndrome. Cyclic vomiting syndrome is defined as the recurrent, stereotypical episodes of vomiting that are acute and typically last less than a week. 3 or more episodes are required per year in order to make the diagnosis. In between episodes, there is no nausea or vomiting. The patient feels perfectly well, and there is no organic cause of their symptoms. The typical manifestations of cyclic vomiting include a very typical pattern that is classic for each patient. The pattern of nausea and vomiting can vary from one patient to the next, but the important part is that for each patient, the usual episode is very similar. The episodes tend to begin in the early morning hours and may include nausea, anorexia, lethargy, or abdominal pain. The episodes will typically last hours, sometimes up to a week. And very important, they're in between these episodes, they feel perfectly normal. They do not have nausea and vomiting on a daily basis. This is very important to differentiate cyclic vomiting from other causes of nausea and vomiting. Other clinical criteria that support the diagnosis include a history of migraine headaches, a family history of migraine headaches, a history of marijuana use, the self-limited nature of the attacks. They often report photophobia, and they often say their symptoms improve if they sit in a hot shower. Although marijuana use is certainly associated with cyclic vomiting syndrome, there's a completely separate entity called cannabis hyperemesis syndrome, and this is also seen in patients who use marijuana regularly. But the difference between this and cyclic vomiting is that these patients have daily nausea and vomiting without the intervening periods of normal health that is required for cyclic vomiting. Alarm signs which should alert you to an alternative diagnosis include severe headaches, altered mental status, gait disturbances, any neurologic signs, GI bleeding, weight loss, or a change in the pattern of their symptoms, or if their symptoms last longer than the typical week. So how do we work up these patients? Well, there should be an initial basic workup which can include blood tests. Certainly Addison's disease should be ruled out. Oftentimes a CT or MRI of the brain is obtained to rule out a central cause of nausea. Other tests that can be considered really depends on the patient's symptoms and how they present. You can consider an upper endoscopy, small bowel evaluation if they have symptoms suggestive of small bowel obstruction, or a CT scan of the abdomen and pelvis. But this is really going to be individualized for each patient. The treatment for cyclic vomiting is sort of threefold. There's abortive therapy, supportive therapy, and prophylactic therapy. Abortive therapy is something they have on hand to take at home right at the first sign of symptoms to hopefully abort the attack or at least shorten the duration of the attack. These include things like Zofran and Ativan. Supportive care, typically that's administered in the ER if they end up being hospitalized, which includes IV fluids, IV antiemetics, and occasionally analgesics. Prophylactic therapy, however, is warranted if the attacks are frequent or severe enough to require hospitalization. So amitriptyline has been used with good success. Typically takes about 1 to 3 months for the benefit to be evident. Dietary supplements with coenzyme Q10 and L-carnitine have also been shown to be beneficial. In one study that looked at coenzyme Q10 when used in combination with amitriptyline resulted in a significant reduction in the vomiting episodes. Cyproheptadine is actually first-line treatment for children, but is also quite effective in adults. Lifestyle changes should also be discussed with these patients. Oftentimes they can identify certain triggers like stress or not getting enough sleep. Of course, you should talk to them about discontinuing their marijuana use. Regular aerobic exercise is beneficial, avoiding caffeine, and avoiding skipping meals or fasting. So hopefully we have a better understanding now for relatively common upper GI functional disorders, globus, rumination, functional dyspepsia, and cyclic vomiting syndrome. Thank you.